Lovely. So, my name's Pawan Randev, and what I'll do is, if it's all right with you, Jane, I'll put up my slide set that I'm going to run through, and there's a fair bit in there. I don't expect you to make any notes at all, and I have sent the whole slide set over to Gemma so that it can be shared on Monday with everybody. Now, I'm just going to shrink it down because this way I can actually see who else is coming into the meeting as well. And if other people do come in, Jane, could you let them in from the lobby if you admit them?
Yeah, okay.
Okay, sure. So just a little bit about myself. I have been a GP for around 30 years. I'm working up at Measham Medical Unit, which is in the northwest of Leicestershire, and I retired from general practice earlier this year to focus on cancer roles, and I am one of the East Midlands Cancer Alliance primary care leads and also a Cancer Research UK GP. And that's my email address down there. It's down there because I really like people connecting with me and asking questions or just getting clarification on what I cover. So feel free at the end to connect with me if there's anything that you want to follow through. So the purpose of today's session is really to cover an area that may not be front and center for practice nurses generally, but people tell you all sorts of things when you're seeing them, and they'll often want an initial opinion, an initial thought on whether they should book an appointment to see the doctor, and so on. And one of the things that we do know about head and neck cancers and mouth cancer is that they are on the rise in Leicester and Leicestershire. So when we think about head and neck and mouth cancers, these diagrams are a very good starting point. They summarize average numbers of head and neck cancers per year, and it's from 2017 to 19 when we have the last complete set of data. So looking at the top left, when we look beyond the mouth, we find that the larynx is actually the biggest ticket item here. So nearly 2,300 odd patients with cancer of the larynx. Then underneath that on the left-hand side, you can see that when you think about the mouth, the top areas are the tongue, and there's nearly 3,000 patients with tongue cancer that were diagnosed per year, but also the tonsils. So 2,000 of those. So very quickly we can see that although there are a lot of structures within the mouth and head and neck, in fact, there are a few very important areas that we need to know about and to be aware of. On the right-hand side, what you can see is the differences by sex. And not surprisingly, because of the differences in smoking rates, you can see that the larynx is very much higher in men than women. But looking at the bottom right, you can see that tongue cancers and tonsillar cancers are actually not too different between the two. And we'll touch on that later on. Now, one of the special things about Leicester, amongst many special things about Leicester, is that Leicester suffers from a very high incidence of mouth cancer. And it's significantly higher than the national average and one of the highest in the country. And I'll illustrate that in the next slide. The other part of this picture, though, is the mortality, because if you're picking cancers up and treating them, hopefully you're having an impact on deaths from this. But in reality, the death rate from mouth cancer is also significantly higher. And it was actually the highest reported in that particular year. Now, when we look and compare Leicester with the rest of the country, you can see that Manchester comes out on top with a rate of 24.5, but Leicester is definitely second with 22. So it is a significant issue here. What I'm going to cover now are the risk factors, signs and symptoms, and then a bit more about Leicester itself and why we've got that issue. And then we'll move into the opportunities to reduce incidence and to pick it up at an earlier stage. So when we think about mouth cancers, looking at the bigger picture, the numbers are rising, and they're rising significantly. The other element is, as I mentioned before, mortality has risen, and mortality has risen by 15% over the last 10 years, and is going to go higher. Now, we know about the main causes, the main risk factor, tobacco and alcohol, but increasingly, particularly for younger patients, HPV, human papillomavirus, is being found to be a big risk. We also have a deprivation gradient issue, as is common with many cancers. So those from the most deprived areas have got a 50% higher risk of death after diagnosis. So with HPV, we often associate that with reduction in cervical cancers. But actually, if you are immunized against HPV, your risks of oropharyngeal and anal cancer are significantly lowered. Then, in a paper published earlier on this year, one of the key elements identified in the Lancet was that actually what we need to be doing is having specific training of health professionals. And that's why we're here today in this webinar, because I want to focus on health professionals within primary care teams. And that includes, of course, doctors and nurses, but also practice nurses. Now, when we look at mouth cancer, and I'm just going to increase the screen if I can. Let me just do something here. Okay, Jane, can you still see that?
Yes, I can, yeah.
Lovely. So it should be full screen now.
Yeah, it is.
And yeah. Lovely. So I've moved on to the next slide. Has that moved with me?
Yes, it has. Anatomy of the mouth, yeah.
Absolutely. So just going back to what I was saying about where you can find cancers, because this then becomes relevant around what you and I can do easily. So on the left-hand side, you can see that the tonsil cancers in men are about a quarter of all mouth cancers, and tongue cancers amount to almost 30%, whether it's the base of the tongue, so the back of the tongue, or the other parts of the tongue. So those are areas that we can look at with a good light source and a tongue depressor. When we think about the modifiable risk factors, we have clearly smoking, also smokeless tobacco, drinking, and HPV. But there is an additional couple of risk factors that are relevant in particular for Leicester. Let's think about the key symptoms of mouth cancer. And these are taken from the NICE guidelines. So these are generally agreed to be important. So a loose tooth that's become loose for no obvious reason, so there hasn't been any trauma or infection. Swelling of the jaw, so that the dentures that people wear don't fit quite right. And usually patients will go to dentists first with those symptoms, but given the difficulty in getting dental appointments, they may well present to primary care. Other elements on the right-hand side include unexplained persisting lumps or bumps, and that's in the mouth, lips, or neck. Now, when we talk about persisting in this context, we mean over 3 weeks, because things like sore throats will give you neck glands for a couple of weeks maybe, and sometimes in children it can be even longer. But if it persists beyond 3 weeks, then you do need to come in to have an examination. So if you see a patient and they report symptoms, the duration of symptoms is a really important part of things. In the same way, sore mouth or ulcers that don't heal within a few weeks. So again, the several weeks, I would say within 3 weeks, because we've all had mouth ulcers either through biting the lips or cheeks while we're eating, or because of stress and you get little outbreaks of ulcers, which settle quickly. So other symptoms include numbness or an odd feeling on the lip or the tongue. And I'll show some pictures later which show what we're looking for there. Now, not so many people realize that if you have white or bright red patches on the lining of the mouth, so usually it's on the inside of the cheeks or along the tongue, these can be pre-malignant changes. And if you find a patient who's got those, especially on the sides of the tongue, then that's something to be aware of and direct that patient either towards GP or towards their dentist who can examine and monitor. For some patients, a change in speech, like a lisp, and you can imagine if you've ever bitten your tongue by accident and you notice that your speech changes, you become very conscious of how you're making your words so that you don't cause the tongue to become any more painful. In Leicester City, we know that Leicester is the first area in England to become a so-called super diverse city, meaning that in the 2021 census, there was no overall majority, but there were more Asian respondents to the census than white British. So this is a pattern that's being followed across the country, and it's likely that Birmingham will become the second super diverse city, but it does have particular relevance to ourselves. Going back to those data comparing Leicester with other comparable areas for ethnicity, we find that actually for the incidence, with Leicester being the yellow bar on the left-hand side, and for mortality, Leicester does stand out. And one of the other important things is that in other areas, the incidence has remained steady. In Leicester, it's actually gone up. So we have a particular reason for focusing on Leicester and Leicestershire. When Public Health did some detailed work looking to see where we were diagnosing patients with that, we found that there were two red spots. And as you can see on the map of Leicester City, they are Belgrave Northeast and the West End. And interestingly, thinking about the risk factors, actually these areas report a low smoking prevalence. So it's not that there are many more smokers in those areas, or in fact drinkers in those areas. So when we look a little further, and Jane, did these slides go on to read Leicester mouth cancer admissions?
Yes, it has, yeah.
Lovely, lovely. So if you look at the top right graph, that if you just take the admissions by age and sex, you see what we would always expect to see. More men in the light blue and around 60 to 70 as the peak. If you look underneath that though, you see something slightly different. If you split it out by ethnicity, and when you look at it by ethnicity, the yellow bars show you that actually there's an earlier peak within the Asian population. So that actually there's a peak between 45 and 49 for men, and also a smaller. And that continues so that there's also a high incidence at 60 to 64, but it goes down again. So we've got these sort of twin peaks going on. And if you are white British, you're more likely to present over the age of 55. If you're Asian, you're actually a little bit more likely to present before the age of 60. So when we try and match this with smoking and alcohol, what we find on the left-hand side is that actually the heaviest smoking areas aren't anywhere near those peaks of incidence of mouth cancer. So we don't think that smoking is causing this. And when you look on the right-hand side for alcohol use, again, there's no clear linkage, with the dark blue being the heavier areas of alcohol consumption. So the traditional risk factors don't account for what we're seeing. And then we looked and we thought, okay, what about dental services? Is it that actually the dental services are particularly poor in that area and people can't get to see a dentist? And in reality, in both of those areas, whilst it's not good, it's not the worst. So we then started to think a little bit further about how we could address this. And I'll show you in a few slides' time some thoughts about what might be causing this raised incidence. But in terms of strategic public health approaches, the plan is to improve awareness of signs and symptoms and support health professionals to make mouth cancer diagnoses, which is what we're doing today with this educational webinar. We're also planning to promote self-checking, and I'm going to show you a brief video in a few slides' time about that. We also need to think about reducing the risk factors, and they include, of course, smoking, and luckily we are doing well on smoking reduction. We also need to work on alcohol consumption and raise the link between smokeless tobacco and mouth cancer. And I'll talk in a minute about what we mean when we say smokeless tobacco. Finally, here we've got the really important objective of improving the uptake of HPV vaccination. And Leicester City is an outlier in terms of uptake because there is significantly lower uptake in the city than in the county, than nationally. And of course, HPV immunisation will protect against many different cancers, including oropharyngeal. The third priority is to try and improve dental access. And this is something that's an ongoing issue nationally, but it's something that we do have in our sites as an ICB and also within public health. But if you look at the third point, we wanted to increase awareness that doctors, as well as dentists, can make that diagnosis and clearly refer in. And I'll show you in a few slides' time some key resources for all of the primary care team, including doctors. When we think about the population's awareness of mouth cancer, one of the areas that we started to focus on with a survey that we conducted last year was looking to see what the usage of these smokeless tobacco products are. And smokeless tobacco is a broad term, but it breaks down into a number of key elements. The first is shisha, and shisha is the water pipe or the bubble pipe that you sometimes see in Indian cafes. And what we found was that if you were of an ethnic minority, you were double the likelihood of using shisha. So 6% rather than 3% in the city and county, or if you look on the box on the right, 6% versus 2% overall. The other smokeless tobacco product, which is actually significantly dangerous, is something called pan. And pan is a mix of ground up betel nut, tobacco, slaked lime, and salt and ash, all wrapped up in a green leaf and chewed after a meal. And the idea is that you chew this, the leaf, it gives you a buzz, and it sort of leaves you slightly lightheaded. It does have addictive potential. And the way that it's used is that you keep it within your mouth and are in contact with your mucosal linings for as long as possible so that you get the biggest buzz, and then you spit it out. And when you spit it out, what you spit out is bright purple because that's what the palm is. Now, the betel nut that's in palm is really important because that accounts for about a quarter of all mouth cancers across the world. And therefore, within our population in that Rushmede area, we have been looking to see whether palm might be a factor. Two other smokeless tobacco products are snus, which is a little pellet that goes between the lip and the lip and the cheeks, and it just dissolves there, so you get the hit of the tobacco without having to either chew or having to smoke it. And of course, there's snuff and chewing tobacco as well. So we can see that people from ethnic minorities are more likely, certainly, to use the shisha and the pan. We also looked within that same survey at awareness of symptoms and also whether people had experienced symptoms. And it turned out that if you were from an ethnic minority, you were more likely to have experienced mouth cancer type symptoms. So as we think about improving awareness, there are some resources, particularly around examining the mouth. And you can see there on that set of photographs how to do it. And also a program of using the quit smoking and cutting down on alcohol. Now that is a little bit out of date. It's no longer Live Well, but I think the number is still the same. I will confirm that. The next thing that I wanted to share was this video, and I'm just going to put it onto the video, Jane, and we'll see if this works.
From the Mouth Cancer Foundation.
Can you see the video, Jane?
Yes, I can.
Lovely. And can you hear the jazzy music at the beginning?
Yeah, yeah.
Lovely. Okay, let's play the video. It's only a couple of minutes.
Okay.
Bite Back at Mouth Cancer is a brand new do-it-yourself check for mouth cancer from the Mouth Cancer Foundation. Examining for the early signs of mouth cancer is easy. Everyone over the age of 16 should do it once a month after teeth have been cleaned. It takes less than 2 minutes and it might just save your life. All you need is clean fingers, a good light source and a mirror. At every step you are inspecting and feeling for any lumps, red or white patches, changes in colour or texture, lingering ulcers or anything unusual. Look at the whole face. Are there any swellings you haven't noticed before? Inspect your skin. Has anything changed recently? Have moles become larger or started to itch or bleed? Turn your head from side to side. This stretches the skin over the muscles, making lumps easier to see. Run the fingers under your jaw and feel along the large muscle either side of the neck using the balls of your fingers. Are there any swellings? Does everything feel the same on both sides? Using your index, middle fingers and thumb to feel inside of your mouth. Pull your upper lip upwards and bottom lip downwards to look inside for any sores or changes in colour. Use your thumb and forefinger to feel around and inside your lips, checking for any lumps, bumps or changes in texture. Use your thumb and forefinger on the inside and outside of the gum, working your way around the gum to feel for anything unusual. Open your mouth and pull your cheeks away one side at a time with your finger to look inside. Look for any red or white patches. Use your finger in the cheek to check for ulcers, lumps or tenderness. Repeat on the other side. Your tongue can be helpful to locate sore areas, ulcers or rough patches. Gently pull out your tongue and look at one side first and then the other. Look for any swelling, ulcer or change in colour. Examine the underside of your tongue by lifting the tip of your tongue to the roof of your mouth. Lift your tongue up and look underneath, then look at the floor of your mouth for any colour changes that are unusual. Gently press your finger along the floor of your mouth and underside your tongue to feel for any lumps, swellings or ulcers. Tilt back your head and open your mouth wide to check the roof of your mouth. Look to see if there are any changes in colour or ulcers. Check for changes in texture with your finger. Make a note of anything unusual. If you've had a cold or a sore throat, swollen glands or an ulcer, or you've just bitten or scalded yourself, for example, these should all heal in 3 weeks. If you have any concerns, see your dentist or your doctor who can advise if you need specialist help. The Mouth Cancer Foundation recommend that everyone over the age of 16 has a professional checkup for the early signs of mouth cancer with their dentist every year. It's also recommended that everyone over the age of 16 does a self-check on their own mouth after cleaning teeth. It takes less than 2 minutes and it just might save your life.
Right. So, am I back to the slides now, Jane?
Well, it's just, no, it's still on the, not
Oh,
yet,
is
no.
it? Okay,
No.
no problem.
Oh,
Let
that's
me,
it, now we are,
that's it.
yeah.
Sorry about that. Okay. So, let me just move up into where we are now. Da-da-da-da-dum. Right, here we go. Right, so we've just seen that. Lovely. So that's a straightforward examination video. And one of the reasons why I like that is that it shows you how you could easily examine the mouth, because you've just seen Dawn Harper there showing how to do it. And that sequence of examination, if you have a pen torch or you've got an oroscope to provide a bright light, and you're wearing with your gloved hands, just pulling the lips down, just asking people to put their tongue out, move it from side to side, just ask them to open wide, using a tongue depressor to look at the tonsils, especially if somebody's had their symptoms for more than 3 weeks, or they do smoke, or you smoke shisha, chew pan, or you know that they actually consume more alcohol than they should be. So it's like with most things in medicine, you're using the overall picture to drive when you look inside a mouth and what you're looking for. Just moving back one step to those risk factors, and we talked about shisha and pan. And one of the things that we did is, if you look on the left-hand side at the bottom map, that's Rushmead, and the yellow arrow is pointing to the Melton Road. And if you look in the middle, you can see the location of registered shisha cafes, and they follow exactly the line of the Melton Road. And if you look on the right-hand side, those are all the places which advertise that you can get pan from them. And again, many along the Melton Road. So we have a sense that the pan and the shisha could be accounting for that twin peak, the earlier presentation with mouth cancer for Asian patients. I worked with a couple of medical students and we undertook a literature review, and part of the plan there is that we're going to be developing particular materials to support cessation of shisha smoking and also to help people become aware of the risks of pan. When it comes to training health professionals, I've got a hit list of people, and I've delivered training similar to this to GPs, to advanced nurse practitioners, and to pharmacy undergraduates and physician associates. But the key thing is that we are all in a position to ask patients to open their mouths we all should have access to a bright light source where we can examine. The next thing that I moved on to was to create, with Cancer Research UK, a complete head and neck cancer toolkit, which is a deeper dive into this area. And I created this with CR UK and with Aggie, who's a dentist. And what we have here are a series of short videos together with an examination video, looking at how we can address this in general practice. There are also some very good pictures of different kinds of lesions so that you can see what you're looking for. This is the examination video, and it's a slight cheat because it says 2-minute examination, but the video itself is about 6 minutes because I do a lot of talking, building up and explaining what I'm doing. The examination itself is very short though, and fits within that 2 minutes. In addition, there is a resource that you may not be aware of yet, which is a source of information on cancer and educational modules on cancer for everybody in the primary care team. And it's called Gateway C. And they have a particular module on head and neck cancers where within 45 minutes you watch a series of videos, interviews with patients, examination, and so on. So it goes into things in more detail. And for GPs, this is certainly part of the educationally approved content. Very easy and completely free. So this is the registration form, very straightforward to fill in. They just want to know some simple things about you, and then you've got access not just to the head and neck module, but about 30 different modules, including cervical screening, bowel screening, and breast screening modules. So if you wanted to have a focus and just deepen your understanding and knowledge, then this is a very straightforward way of doing that. I just wanted to show some conditions that you're likely to see as you start looking inside the mouth. And whenever we get GP trainees in, one of the things that happens is that they start seeing things that are actually not abnormal. They're part of the normal range of things that you can see. And in particular on the top left, these little white spots, and here these are under the upper lip. They're called Fordyce spots, and looking at them, you can see that they're spread out all over, and they're little things. They haven't coalesced or come together like an ulcer. That's a normal variant. In the top middle, there's a little fluid-filled cyst called a mucocele, and that also is quite normal. The polyps, normally, if you saw them, I would refer them to a dentist, because when they're in the mouth, you have an uncomfortable feeling of something being there, and the dentists are in a position to be able to remove them if needed. Bottom left is a condition called geographic tongue, and this is very common, and it's, as you can see, just really quite superficial on the tongue. In the middle, there's something that people get very alarmed about called hairy tongue, commoner in people that smoke. And so you might see that, but there's no ulceration, and it's spread out all over the tongue. Finally, bottom right is something called the mandibular tori, and this is quite normal. And the view that you're seeing there is the bottom of the mouth with the tongue lifted up. And one of the important things to do when you're examining patients, you're looking inside the mouth, is just get people to lift their tongue up so that they're touching their hard palate, and shine the pen torch down there. And if you see those are quite normal findings. They're symmetrical, they're on both sides, and they don't look ulcerated or inflamed. The kinds of things that we do look for, if you look at the top left, the squamous cell carcinoma, so you can see that the normal gum just on the right-hand side and the swelling just over there. And you can see that it's different to the other bits, and it's just there. It's not on the other side either. So that's a squamous cell carcinoma. Other carcinomas which are squamous cells that you can find are around the cheeks. And some people believe that this is due to repeated trauma. For example, badly fitting dentures is typically one of the reasons for that. But here you can see again, it looks very different from the surrounding tissue. And on the far right at the top, again, you've got something which is asymmetrical. It looks very different from the other bits of tissue around it. So the asymmetry, the fact that it looks really different, it's just, and in some cases looks more red, that's really important. On the bottom left, you can see a squamous cell carcinoma on the lower lip. And these actually are supposed to be more common in people who have outdoor occupations, but sometimes it can be to do with chronic changes around the lip. Finally, one group of people that are at particularly high risk are the refugees and asylum seeking communities. And you can imagine that to get to this country, you've left a country which is in some degree of chaos, and you may well not have had access to medical or dental care for years. Those countries often have higher smoking rates, and people are less likely to have had regular checks and have those risk factors. So one of the areas that we're introducing is the concept of, for those practices that do cover these areas, to have an awareness that this is a higher than average risk population. We also include the homeless population in this group as well. And so when you assess somebody who's in those groups, then if you are able to build up your confidence to look inside the mouth and to ask the questions about symptoms and risk factors, then that is something that's of particular relevance here. And I know that we have asylum seeker practices, but also that those people are spread around the city as well. So that's the end of this presentation. And Jane, if you wanted to pop your camera on as well, and we can have a chat about any questions you might have or any observations or thoughts about what we've covered so far.
Well, it was interesting to see what the reason is, because I've had quite a few friends actually and colleagues that have had cancer of the mouth.
Really?
Yeah,
Right.
yeah. You never used to hear about it at all, did you, really?
No.
But just recently, during the last 5 or 6 years. I mean, one, I just put it down to perhaps she did smoke. But obviously she lives in Leicester. Another one is a very young one. So I don't quite know what's caused hers really. She lives in Melton and she's only 30 and she's had it on her tonsil, and apparently now that's been taken sorted, and she's had radiotherapy treatment last year. Unfortunately, she had a scan and then it's found to be near her voice box now, so they're obviously going to go in again. And she's only a young mom as well, so I don't quite understand why she's got it.
It's shocking, isn't it? And I've had a number of patients under 40 now.
That's what this one was.
Presented, and those cancers are the ones that are more likely to be HPV driven.
Right, yeah.
So unfortunately, your friend may not have had access to HPV immunization at that age, which is one of the reasons why promoting HPV immunization in boys and girls becomes such an important part of things, because if we can drive up the immunization rates, then gradually, as people get older, the incidence and that sort of preventable cancer in a way, but only preventable if you
Yeah.
have the immunization is there. And that was interesting to hear of your friend. Was your other friend who smoked, was she or he older?
She was in her late 50s.
Yeah,
I was a bit shocked, really, because she actually didn't stop smoking, even though she had it on her tonsils. And she did
really.
undergo treatment, yeah, and she did survive, but sadly it's now come back in the lungs, which,
Yeah, yeah.
I presume is to do with smoking.
It is. And interestingly, one of the things that we know, actually the other way round from your friend, is that if you're referred to a lung cancer, suspected cancer pathway, a 2-week wait referral for lung cancer, and they give you the all clear, there's a 5% chance of you developing mouth cancer or laryngeal
Right,
cancer in the
right.
5 years afterwards.
So this
And
was
so
completely the other way then, isn't it?
this was the other way around. But you're absolutely right to realize the shared risk factor. And so now in the lung cancer clinics, they have a well-established smoking cessation offer so that when people do come in, they are given that advice. But it's one of these things that you can offer it and try the
I
established
know.
treatments. And for some people, they
Mm,
are able to give up. And unfortunately for
mm,
others, it's
mm,
too difficult to
mm,
make that transition at a challenging time anyway.
mm. She's on stage 4 now, though. So
Oh
she,
dear.
when they found it in the lungs, it was stage 4. In fact, I had a text from her only a couple of weeks ago, and I do feel that it was perhaps a goodbye text, actually.
Really?
Yeah.
Oh dear.
So
Yeah.
so
Yeah.
quite sad.
So I'd be interested to know what you think, Jane, about how we get the message out there.
Hmm. Well, obviously, we're in the social prescribing team, and obviously, that's why I was quite interested in this, because I've got friends and colleagues that have had this type of cancer. So obviously, I will be sharing all this with the rest of my team.
Yeah.
We're a big team of 14, so I'll be sharing this. Um, Perhaps like workshops and things like that, or
Yeah.
going into the libraries, the stands. Um, I mean, I've got 3 adult children, and it's been on my mind because obviously you see the rates going up
Yeah.
so much. And as I say, when I was little, you never really heard of oral cancer at all,
Yeah.
any type of that. But now, obviously, um, yeah. Yeah, so I would say doing the stands, we do a lot of going out in wellbeing clinics and stuff like that and putting stands out. And I know it's a bit boring doing that, but it perhaps will get the
Yeah.
message across a bit
Yeah.
better. And also going into schools, the
Yes.
secondary schools and that would perhaps be really good, because perhaps if the parents don't sign to say that the children can
Yeah.
have the injections, the vaccinations, perhaps the children then they are more aware.
Yeah.
Um,
I think
it's
that's a really good idea, Jane, especially for the children. And
yeah,
there is work going on at the moment to engage with those 16 to 25-year-old girls that
mm,
haven't been immunized.
yeah,
And I'm afraid there's just so much misinformation
yeah.
about it.
Mm, mm, mm,
So I think that working with schools is something that I think we can highlight, and
mm.
especially given that age, perhaps those children that are coming into sixth form,
Yes,
that
yeah.
would be a key group, and
Mm,
have it as part of their PHSE or as a standalone sort of health thing. Because I think my experience is that if you go in with a sort of health and well-being offer,
mm.
because everyone wants to be healthy and feel
Yeah,
well.
yeah,
Whereas
yeah.
if it's focused on cancer, it's very
Cancer.
easy at that age to
Mm,
put it to one side.
yeah.
But if it's sold as a health and well-being, and actually having this
Mm,
immunization will help to prevent a whole series of cancers.
yeah, yeah.
And we're
Yeah.
already seeing in countries where the program's been established, and for example, in Scotland, they have done an audit where they've shown that actually they had virtually no cases of cervical cancer
Really?
in
Wow.
1 year. Yeah. And
Mm.
in Australia, it's pretty well wiped out. And genital warts, which is the other sort of big thing that's associated with HPV, that's gone right down as well.
Right.
And in England, we've had immunisation for boys at a later point than we have had just for girls. So girls are actually getting even more protection going forward. But at the same time, it's the boys that we need to try and get to as well, because, So we do have a big programme of that with public health colleagues that we're bringing forward. And the other element here is around, as you highlighted, social prescribing and educating and sharing these materials with those people that are able to go out in the community. So if you had, for example, a professional group that you wanted this to be shared with, you'll be getting the slide set anyway.
Yeah.
And hopefully, if I've managed it, the recording will have recorded, so you can always share that with people. And if you wanted to consider a more targeted approach or think about how we can focus on schools, the other big area that I've thought about has been local authority employees.
Definitely.
Because
the local area coordinators,
because whilst we've had cutbacks in sort of staffing and things, actually, this is something where I feel that you only have to influence a few people who then spread the word. And that word
that's what we think.
And that can be spread in religious areas. It can be spread through supermarket. We've got a variety of things that we can do. But the key thing is for us to believe that we can make a difference. And as you've seen, we've got all of the tools with which to do it. And
so, it was interesting about the cafes, because I didn't realise about the pan cafes. So that was interesting.
And what happens is that you can just buy pan and just take it. And people just do not know. And in India, Pakistan, the Middle East, it just causes masses of mouth cancer. And actually, I was talking to a dentist from South Africa who was telling me that in South Africa, where they have a very different health system, the time when people come to see the dentist is when they have a cancer. And they've been smoking shisha and using pan, etc. So that's a project where I'm actually working with community pharmacists in Belgrave and the other areas, on the grounds that the community pharmacists often are able to speak the same language. So there are a lot of Gujarati pharmacists, and they have much better opening hours than primary care does. As well as an established relationship where they see people month on month or every couple of months to pick up prescriptions. And there's a degree of confidence. So the training tool for community pharmacists includes a risk calculator as well, so that once they understand how to look in the mouth, they can actually grade the risk of that patient and then signpost them on to doctor or dentist for review. So that's another tool that we can use. But I think if you were to go back to your group of social prescribers, and if you have a wider WhatsApp group, then I'm very happy to talk to the whole group about this and talk about risks, harm reduction, together with recognition, and also sharing that self-examination video. I'd be interested to know what you made of that self-examination video, because this is the first time I've used it in the wild.
Yes, it's very basic but interesting, and it's very informal. So I thought it was very good. It's very good.
I think for me, what it shows is that actually, if you can do this yourself as a lay person, you as somebody with a degree of knowledge and a light source can actually do all of that. It's not difficult. The important bit is to be systematic, and in the examination, the slightly longer examination video of me doing with somebody, I talk you through each individual step. I break it right down.
Right.
and
Okay.
explain what you're looking for. So if you did want to learn a bit more, and it's also a skill that once you've got it,
Yeah, you can
and you've
pass
done a
them.
few of them, then you're able to
Mm.
pass it on to
Mm.
students and others that are
Yeah.
working with you.
Yeah.
It's not difficult. Yeah.
No. The dentists as well. A lot of I don't know, the younger generation don't tend to go to the dentist because of the costs now.
That's right.
So
Yeah.
I think, you know, trying to hit it, how important going to a dentist is perhaps as well,
Oh,
going from it
definitely.
on that angle as well.
Yeah. Yeah.
Um,
And that's what we're trying to do with our public health colleagues. And
mm,
as you can imagine, the overall challenges in supply of
yes,
dentists within
yes,
specific areas. But we're awaiting a plan or
yeah,
two.
yeah. But
And
the young adults, they don't want to pay,
yeah,
do they? They don't realise
no,
the importance. But if they realise that that could save their lives as well, that might
yeah,
make a difference.
absolutely right. Yeah. And that's maybe all part of a message that goes out to
Out.
schools. And
Yeah.
I think it'd be really interesting. And if you have schools in your remit or connections within schools, and we wanted to try this out, it'd be really interesting to do, because one of the things that I found, I've connected with a local school where they have a sort of a medical people that want to do a nursing or medicine.
Yeah.
And they form their own club and they get together at a lunchtime. We've just gone in and talked about general medical topics to them. And that's one opportunity. But what I suspect is actually it's something that's so important, it should be available for everybody.
Yes.
And so, having perhaps a wider assembly type thing or a workshop or series of workshops, I think that there's lots of potential there, and
Yes,
particularly using the idea of HPV, because of course, as GPs, we're able to offer and get paid for delivering the HPV immunization to the children that haven't had it.
Yeah.
So I think that there are lots of exciting possibilities, and I hope that once you've seen the overall slide set, and by the way, within the set when you get it, anything that's an image, if you click on it, it'll take you through to the website.
Yes.
So they're all preloaded like that.
Lovely.
So any of the things that you want to follow up or want to look at the video or whatever, just utilize them. So Jane, I think that it's been a very useful one-to-one teaching session, and they're always the best.
All right.
I'll share this with I'll share the recording with Gemma, who will then pass it on to the whole group so that people will be able to see it all, and we'll get the materials out there. But have a really good weekend.
Yes, and you. Thank you very much.
Thank you for attending. Okay.
All right then. Thank you for your time. Bye.
Bye-bye.